Good afternoon, respected HOD sir, teachers, and my colleagues. Breast cancer is the second most common cancer in the year 2020. There were 2.3 million women diagnosed and 680,000 deaths globally. To shed more light on this topic, today with a batch of A1 are going to present a case on carcinoma of breast. A 45-year-old female AOP with the following complaints: lump in her right breast since 4 months, pain in the nipple since 2 months, bloody discharge from nipple since 25 days, retraction of nipple since 10 days. On local examination, there was hard lump of size 6 into 6 centimeter in the right upper outer quadrant, painful retracted nipple with bloody discharge, puckering of skin over lump, purdy orange appearance, enlarged lymph nodes in the right axilla, opposite breast and axilla were normal. On investigation, breast ultrasound confirmed the clinical findings. On mammography and ultrasound examination, lesion was characterized to be malignant. FNAC was done. It was conclusive of locally advanced breast carcinoma. So now I would like to call upon my colleague Vasundhara to present her topic normal anatomy of breast.
Good afternoon, everyone. I will be now discussing about normal anatomy of mammary gland. So a part known as axillary tail of Spence, which pierces deep fascia and enters into axilla. Next is its shape and extent. It is hemispherical bulge extending vertically from second to sixth rib and horizontally from sternum to the mid-axillary line. Relations of mammary gland. The breast lies on deep fascia, which is also known as fascia by retromammary space, which is a loose areolar connective tissue. This space allows free movement of breast and chest wall. Muscles which lie deep to the breast are pectoralis major, serratus anterior, and external oblique muscle. So it was all about from my side. Now I will hand over the screen to Ananya. She will be discussing about structure of memory. Thank you, Vasundhara. I would now like to briefly discuss about the structure of breast.
Speaker's camera should be on. Speaker's camera should be on.
Okay, sir. So, camera is on. We are visible. Okay. So now to briefly discuss about the structure of breast. Skin, which is the main covering part, parenchyma, which is the secreting part, and stroma, which is forming the main framework of the breast. The skin has the nipple and the areola. So, nipple is a conical projection which is present at the level of fourth intercostal space, about 10 centimeter from the midline. It is an important landmark which is pierced by 15 to 20 lactiferous ducts. The baby suckles on the nipple to get the milk which flows through the lactiferous ducts. Apart from it, it also consists of circular and longitudinal muscles, which on contraction can raise or flatten the nipple respectively. Around the nipple, we can see is a darkly pigmented area which is known as the areola. The areola is devoid of any fat. It consists of sweat. It consists of sebaceous glands which get activated during the lactation. They form tubercles known as the tubercles of Montgomery. These tubercles release some oily secretions when lactation to prevent the cracking and drying of the skin. The next part is the parenchyma. The parenchyma is the main secreting portion. It is consisting of 15 to 20 lobes. As we can see here, each of the lobe is made up of alveoli clusters. The alveoli clusters will release the milk, which will go to the lacteous which are present at the and finally what is the stroma? The stroma is the main supporting framework. It has two parts. The fatty part forms the main bulk of the gland, whereas the fibrous part forms the septas known as the ligaments of Cooper. These ligaments of Cooper are responsible for keeping the breast upright by adhering the skin and the gland to the pectoral fascia. With this, I would now like to move on to the nerve supply of the breast. As we can see from the diagram, it is supplied by the anterior and lateral cutaneous branches of fourth to sixth of second to sixth intercostal nerves, and it is visible that the nipple is supplied by the cutaneous branch of the fourth intercostal nerve. With this, I would like to now call Anirudh for the presentation.
Thanks, Ananya. Now I will talk about the blood supply and the lymphatic drainage of the breast. So first, we will understand the breast. The breast is a highly vascular organ which receives its blood supply from the branches of three main arteries. These are the axillary artery, the internal thoracic artery, and the posterior intercostal artery. The breast receives its blood supply from the perforating branches of the internal thoracic artery and the lateral branches of the second, third, and fourth posterior intercostal arteries. To be more specific, it receives its supply from the three branches of the axillary artery, which are the first one is the superior thoracic artery. It arises from the first part of the axillary artery, runs between the two pectoral muscles, and gives off branches to the breast. The lateral thoracic artery runs along the lower border of the pectoralis minor and gives lateral mammary branches to the breast. The abdominothoracic artery gives a pectoral branch which has a course similar to that of the superior thoracic artery. It runs between the pectoral muscles and gives off mammary branches to the breast. So now we would have a look at the venous drainage of the breast. As we see in the following diagram, the veins follow the corresponding branches of their arteries and they converge towards the base of the nipple. Here they form an anastomotic venous circle where the veins divide into a superficial and a deep set of the veins. The superficial set of the veins, they drain into the internal thoracic vein, whereas the deep set of the veins, they drain into the axillary vein and the second, third, and fourth posterior intercostal veins. So this was all about the blood supply of the breast. Let's move on to the lymphatic drainage. The lymph from the breast is drained by the two groups of lymph nodes. These are the axillary lymph nodes, which drain about 75% of the lymph. Mainly, the anterior axillary group of the lymph node are involved in the drainage of the lymph from the breast. The other is the anterior thoracic, also known as parasternal lymph nodes, which drain about 20% of the lymph from the breast. The remaining 5% is drained by the another group of the lymph nodes. These include posterior intercostal nodes, subdiaphragmatic and subperitoneal nodes, deltopectoral nodes, and supraclavicular nodes. So, we have two sets of the lymphatic vessels which drain the lymph from the breast. These are superficial and deep set of the lymphatic vessels. These lymphatic vessels, they receive their lymph from a plexus known as the Sepi's plexus, which is present just beneath the areola. It drains the lymph from all the parts of the breast and provides it to the lymphatic vessels. According to Burns' surgical classification, the lymph from the breast is axillary nodes into three levels. As you can clearly see in the diagram, these are level 1, 2, and 3. The level 1 involves anterior and the posterior group of the nodes, from where the lymph passes to the central and the lateral group. This constitutes the level 2. From the level 2, it finally reaches the spinal of the nodes, which constitutes Burn's surgical classification. From the level 3, it finally drains into the supraclavicular node. The right supraclavicular nodes drain into the lymphatic duct, whereas the left supraclavicular node they drain into the thoracic duct. So this was a complete aspect of the lymphatic drainage of the breast. This I would like to hand over the presentation to Anukriti.
Good afternoon, everyone. I would be presenting the histology of breast. So, starting off with an overview of the gland, the given diagram shows a numerous these lobules further cluster up to form memory lobe. There is a lactiferous duct, which at the terminal end forms a dilation, which is called the lactiferous sinus. These sinuses serve as the reservoir of milk, and at the time of lactation, these eject the milk in through the nipple. The given diagram also shows the two major differentiating phases of the mammary gland, which is the lactating phase and the non-lactating phase, with a comparatively larger lumen of the alveoli in the lactating phase. Talking about the mammary lobule, it consists of two types of tissues, mainly which include glandular tissue and the connective tissue. And the changes which take place during the development of the breast is mainly at the level of glandular tissue. As it can be clearly seen in the diagram, from birth to puberty, the glandular tissue grows, and at the puberty, due to the secretion of various sex hormones like estrogen, the ducts which are previously formed up till puberty begin to proliferate, and at the adult stage, the few alveoli begin to be seen. At the time of pregnancy, under the influence of hormones like progesterone and HPL, various glandular buds are formed, which at the time of lactation are filled with milk secretions, which is secreted by alveolus. Secretion is secreted by alveolus. Two components, the lipid component and the lipid component is secreted by and the protein component is secreted by merocrine mode of exocytosis. After the end of lactation, the alveoli shrinks and the excess of the milk is reabsorbed, and the glandular glandular tissue is restored in the resting stage. Now, as previously discussed, the mammary gland consists of two main stages, which is the resting mammary gland and the lactating mammary gland. The difference which main differentiating feature between the resting and lactating mammary glands are in the resting mammary gland, there is major row connective tissue in comparison to the glandular tissue, and also the glandular tissue which is already present is very poorly developed, and the alveoli shows cuboidal epithelium with a wider lumen. However, the excretory ducts are narrow due to the absence of any secretion. Contrastingly, in the lactating mammary phase, there is larger amount of glandular tissue in comparison to the connective tissue. The secretory units are numerous, well developed, and the alveoli show columnar epithelium due to the rapid secretion. And the ducts have wider lumen which is filled with milk secretion. The given slide shows the difference between the resting mammary phase and the lactating mammary gland. In the resting mammary phase, one can clearly appreciate the larger amount of dense connective tissue with comparatively lower amount of glandular tissue. Empty lumen of the ducts can also be visible clearly. However, contrastingly, in the mammary gland, the amount of connective tissue is highly reduced, and the amount of alveoli and the number of alveoli is highly increased, and also the duct show the blooming structure with vital lumen and secretion. So that's all from my side. Now I would like to call Ashwini to present the development of breast.
Thank you, Anukriti. Good afternoon, everyone. I will be briefing you today about the development of the breasts. Breasts are modified and highly specialized type of sweat glands where development is same in male and female embryos. The first evidence of mammary gland development is seen in the fourth week of intrauterine life when mammary crests develop along each sides of the ventral surface of embryo, extending from the axillary region to the groin. In humans, these disappear except at the part of the site of future breasts. Involution of mammary crests in fifth week produces primary mammary buds. These are the downgrowths of the epidermis, which is the ectoderm, into the underlying mesenchyme due to its inductive influence. Primary mammary buds eventually form several secondary mammary buds, which develop into lactiferous ducts, followed by their canalization due to placental fetal hormones in the circulation till late fetal period. During the late fetal period, the epidermal site of origin of mammary glands become depressed to form mammary pits. Soon after birth, the nipple raised from the pit due to proliferation of surrounding connective tissue of the areola, which is the pigmented area. Breasts of neonates have lactiferous ducts without alveoli, which on development later are sites of milk secretion. In females, the breasts enlarge rapidly during puberty due to the action of estrogen, mainly because of development of mammary glands and the proliferation of fibrous connective tissue and fat associated with them. In males, there is less development of breast due to the lactiferous ducts being rudimentary throughout their life. Proceeding with the anomalies of the breast, there may be amastia, absence of the breast, and athetia, absence of nipple, due to the failure in the development of mammary crest or disappearance of it. There may be polymastia, supernumerary or extra breasts, or polytheria, supernumerary or extra nipples. There may be gynecomastia, that is development of breast in a male, which is usually observed in Klinefelter syndrome, that is XXY chromosome complement. Now, Vivek will take over the presentation.
Thank you, Ashwin. Good afternoon, everyone. So I will discuss about the effects of breast cancer and how it spread to the different parts of body. The following are some symptoms in case of the breast cancer. Due to the cancer cells may infiltrate the suspensory ligaments, the cause which the breast becomes fixed due to the contraction of the ligaments, the retraction of skin or the puckering of skin occurs. Then the cancerous cell may infiltrate the lactiferous ducts, which cause the retraction of mucus. Uh, it produces the edema in the skin and produces the appearance like that of skin of orange, and it is called as powdery orange appearance. It may produce the abscesses in the breast, and it be drained by the first lymph nodes. It drains it. It is the sentinel lymph node. Some other more symptoms are given below, like the lumping or the thickening, swelling, change in breast shape, skin dimping, armpit lump or pain, skin texture change, skin irritation, nipple discharge, wound in nipple, change in how the nipple looks. Then, how the breast cancer spreads to the different parts of the body because of the communication of the superficial lymphatics of the breast across the midline through the external lymph node. It can be spread to another breast through the lymph vessel. It may spread to liver, pelvis. So, by the it may fall in the ovary and may spread there um, to Kenberg tumor. Through the hepatic lymph nodes, it may spread in the liver and through the subperitoneal lymphatics, it may spread in the uh, ovary and to the liver. Besides of the lymphatics, it can be spread through the segmental veins to the vertebrae and to the brain. Through the posterior intercostal veins, it spread to the segmental vein and the venous plexus within the vertebral body, and then it passes through the brain and the vertebra. In this diagram, we can clearly see through the uh, parasternal lymph nodes, it may spread to the opposite wrist, uh, to the liver and to the ovary. It can be spread to the bones like the humerus, rib, sternum, and femur. Okay, thank you. Next, my colleague Ayush will be proceed next topic.
Good afternoon, everyone. Good afternoon, everyone. My topic is investigations of the carcinoma of breast. So, first of all, I would like to inform everyone that investigations of carcinoma of breast in which the regular screening should be done at regular intervals because the symptoms which are formed due to carcinoma of breast are not seen very prominently in every person. So the investigations include two methods, the conventional method and the new and experimental techniques. So in conventional methods, there are three types. The first one is the imaging test, which includes the mammogram, which uses low doses of X-rays. The second one is the breast ultrasound. This is done in cases of fluid-filled cyst because mammogram cannot detect them. The third one is the breast MRI, which shows us the detailed picture. It uses radio waves and strong magnets. It is combined with mammograms because some cancer which can only be seen in mammogram cannot be seen in MRI and vice versa. Now, in the next slide, we are going to see the new and experimental breast imaging tests. These are divided into again three parts. The first one is the radionuclide imaging, which is also called as nuclear medicine test. It uses a tracer which is injected into the blood. The tracer gets attached with the cancer cell because of the antigen antibody reaction, and further we can find the image of it. The second one is the PEM, also called as positron emission mammography, which is a subdivision of the PET. It uses the positron particles to obtain the image of the carcinoma of breast. The third one is the elastography, which tells whether the possible carcinoma is of the benign type or the malignant type. It uses the technique that the cancer tumors can be firmer and stiffer than the normal breast cells, because of which we can differentiate them and state the carcinoma of breast is present or not. Now, my colleague Yash would further continue the slides talking about the treatment of the carcinoma of breast. Thank you.
Yes, you are on mute. So unmute yourself. Just.
Good afternoon, everyone. Now, I will talk about the surgical treatments of the breast cancer. There are two types of surgical breast cancer treatments. The first one is the lumpectomy, which is also called as the breast conserving surgery or the partial mastectomy. Uh, in this surgery, the surgeon removes the tumor with a small margin of healthy breast tissue to ensure that all cancer cells are removed. but the drawback is that it leaves a permanent scar on the breast tissue. Now, in diagram given below, there are three surgical incision options. Options are given, which include the axilla, perialveolar, and inframammary incisions. The perialveolar and the inframammary incisions are good option as they allow the concealment of uh, scarring below the bras and the bathing suits. The surgeon generally recommends the lumpectomy when the cancer is in the early stage or if the tumor is small and single, and not recommended the lumpectomy when the cancer is metastatic or in the last stage. Now to the other type of breast surgery. This is called a mastectomy, uh, in which the surgeon remove the whole breast tissue with the fat present beneath it. When multiple tumors are present, uh, the mastectomy is preferred, and there is a less chances of reoccurrence of cancer in mastectomy than the lumpectomy. Uh, there are different types of mastectomy present, which are shown in the diagram given below, which includes the simple mastectomy, the modified radical mastectomy, and the radical mastectomy. The modified mastectomies are performed when the cancer spread to the chest wall. In the radical mastectomy, the surgeon removes the breast tissue, fat, the pectoralis major muscle present in the chest, and the axillary nodes. Over time, a new technique called as the modified radical mastectomy is emerged over the radical mastectomy, uh, in which the breast tissue, fat, and the axillary lymph nodes are removed, thus spare the removing of the muscle. According to a survey, the 5-year survival rate of the radical mastectomy is 81%, while for the modified radical mastectomy, it is 85%. Now, to the latest one, flap reconstruction, it is performed in women who have undergone breast surgery who wants to their breast appearance. In the procedure, the skin, fat, and the muscle from the upper back region is moved to the front of the chest with the blood vessels intact. The lattice dorsal flap is preferred over other flap as it provides ample bulk for the reconstruction because of its greater space area and produce the breast with the projection. The advantages of the lattice dorsal flap is that it is robust and having low failure rate, while the disadvantage include the firmer filling on the breast and the long time during the surgery, and also the loss of sexual sensation over the breast. Although the success rate of the lattice dorsal flap is very high, it carries a certain risk like the infection, hematoma, and a seroma. Now this is all from my side. Now my colleague Nagnat will explain about the chemotherapy and the radiotherapy. Thank you.
Thank you, Yash. Hello, everyone. As my friend described you the part of surgery, along with surgery, there are other ways of treatment like radiotherapy and chemo. Treat cancer. Talking about the radiotherapy, in this type of treatment, radiations like X-rays or particles are bombarded on the cancer cells to kill them. Generally, lumpectomy is followed. This cancer or cells are in the different aspects of investigation. Now there are three types of radiotherapy. First, in which radiation source is outside. Second one is internal radiotherapy, which is also called as brachytherapy, which is and third is radiation, in which source is especially in metastasis of cancer. Because in metastasis, the cancer is spread all over the body, and it is very dangerous to give huge radiation or exposing the body to the such huge radiations. It is not a practical thing. So there is a chemotherapy for this. For talking Talking about chemotherapy, different types of drugs are given to the patient which inhibits or kills the cancer cells. Chemotherapy can be given intravenously by automated machines manually. There are there are two types of chemotherapy. First is adjuvant, which is different type of examples of the drugs given in case of chemotherapy. These drugs are generally given in combinations of 2 to 3 for their best result. As mentioned in the radiotherapy part, this can be very useful in the carcinoma, which may chemotherapy is used for the surgery to strip the area of the cancer site, to avoid the extensive surgery. This is from my
Sir, it looks like some technical glitch. We'll be back in a minute, sir. Hello.
No problem, no problem.
Yes, sir. Yes, sir. Yes, sir. They are back, sir. Yes.
Thank you, Nathna. Good afternoon, everyone. Now I'll be elaborating on the surgical complications of breast cancer surgery. Seroma is the most frequent complication of breast cancer surgery.
Zoe, the screen is not on. Yeah, it's on.
Screen is not on screen. Sir, हो रहा है शेयर. Seroma is the most frequent complication of breast cancer surgery. Sometimes fluid collects near the wound and around the armpit. This accumulation can cause pain, swelling, and increased risk of infection around the area. If painful, the fluid is drained with a needle and surgery. Otherwise, it normally goes away on its own within a few weeks. Hematoma. Occasionally, blood collects in tissues around the wound due to damage to the local blood vessels. This can cause pain, swelling, and the area might feel hard. The nerves which can be damaged in mastectomy are medial and lateral pectoral nerves, thoracodorsal, long thoracic, and intercostal nerves. Nerve injury leads to numbness, tingling, or shooting pain in the armpit, shoulder, or chest wall. There is a risk of long-term swelling, that is lymphedema, in the hand and after removal of lymph nodes. Some easy measures to counteract lymphedema are exercise, which helps in improving the drainage, bandages, wearing compression sleeves or plastic bandages, and prevent accumulation, heart, and massage therapy. Some of the complications breast cancer surgery are blood clots developing in the leg, bleeding from the infection. Now, I'd like to hand over to Shrishti.
Good afternoon, everyone. I'm going to elaborate on the topic palliative care. What is palliative care? Cancer and its treatments causes physical symptoms and side effects, as well as social and financial effects. Cumulative management of these risks is called as palliative therapy or supportive care. Its main objective is not to cure the cancer, but to treat the unpleasant symptoms, anxiety, depression, stress, grief, etc., and enhance quality of life. These suffering undergone by both the patient and the family members. Any person, regardless of age, type, and stage of cancer, may receive this type of therapy. Often people get confused between palliative care and hospice care. So, hospice care is a type of palliative care. Hospice care is an end of life for people who are at terminal stage of cancer. Some or cases, a patient choose not is designed for their situation. This also provides support for the family. Starting hospice early may be able to provide months of meaningful care and quality time with the loved ones. Now I will discuss the delivery of care, which is also called as continuum of care. This diagram shows how palliative care is different from the hospice care. After diagnosis of cancer, disease-modifying treatment should be started immediately, followed by palliative care, which reduces the pain symptoms. Hospice care is suggested at the terminal stage of the illness. Palliative support is kind of support given to the individual's family after the person's death, financially or or for their loved ones. Thank you. Now I would like to call
I take this opportunity to develop on the understanding
Sir, actually, the last part was the vote of thanks, but due to range problem, we were not able to hear it. We has finished up with the seminar right now.
Uh, Excellent presentation, Vivek and team.
Yes,
Shyam
sir.
Kishore sir, are you there? Before sir comments, I would just like to tell that it was absolutely fabulous. The first seminar of 2022 batch, and I would like to congratulate the whole team and the batch teacher, uh, Dr. Vivek. Keep it up. You have raised the standards of the seminar very nicely, and I'm very happy with your presentation. Everybody was very confident. You knew your topic, you knew your subject very well. Very nice.
Thank you, sir. Students have really outdid themselves in last 3 days because not only making this seminar, they were attending the classes at physiology, biochemistry, anatomy as well. And even after this, they were able to present with this within 3 days of time span. So I'm really proud of them. Uh, all done, all the well, very well done.
No, no, we are also very proud of you, all of you. Saturday afternoon, I come home and I sleep, but
Thank you,
I
sir.
stayed awake just seeing the first two presentation, and I decided no, I have to attend. And you have enriched my knowledge. Thank you so much.